Hello, everyone. Welcome to today's HealthLine webinar from the American Association of Kidney Patients titled COVID-19, the Omicron variant and kidney patients. My name is Erin Kahle, and I am AAKP's Director of Patient Insights, Data Analytics, and Advocacy. I oversee our patient research and education activities, as well as our grassroots engagement activities, including our Ambassador Initiative, which comprises highly motivated and engaged patients, caregivers, and living kidney donors around the country and the globe. AAKP's HealthLine webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. This is especially true during national emergencies such as the coronavirus pandemic. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing the federal, academic, and private sector research, shaping the next generation of healthcare services, assistance programs, and innovative new treatments. We encourage you to respond to our flash surveys and other engagement opportunities. At this time, I'd like to introduce AAKP Vice President and Chair of our Veterans Health Initiative, Ed Hickey. Ed is a Marine Corps veteran and a kidney patient who manages many of our efforts on Capitol Hill. Ed, thank you so much for joining us today.
Thank you, Erin. It's good to be here. First, I want to thank everyone who has joined us today and encourage you to join AAKP as a member if you've not already done so. AAKP is the largest independent kidney organization in the United States, established in 1969. As a kidney patient, a family member, or a living kidney donor, you can join AAKP for free and receive updates from AAKP where your voice is needed to inform innovation, policy, and impact patient care. AAKP has hosted a dozen webinars since the onset of COVID-19, providing the latest updates from federal partners, including the Veterans Administration and the Centers for Disease Control and Prevention, kidney healthcare professionals on the front line, and those impacted by kidney disease themselves. Today's webinar is no different, and I'd like to thank our two special guests from George Washington University. George Washington University has been an important partner with AAKP in providing many years of instruction, including our annual Global Summit on Kidney Innovations, which will take place this May. You can also view the sessions from previous years on demand, and the link to those provided will be provided later in this presentation. Today's webinar will provide important updates on the impacts of COVID-19 and variants like Omicron and the impact that they have on the kidney patient population. Our speakers will also share information about the use of masks and other safety measures you should take. I'd like to turn it over to my friend and colleague, Paul Conway, Chair of Policy and Global Affairs for AAKP. Paul is a kidney patient of over 41 years, receiving his transplant 25 years ago. Paul will discuss some of the data we collected during a recent AAKP flash survey. Paul, turn it over to you.
Hey, thank you very much, Ed. And for those who are watching, Ed Hickey is not only a veteran of the U.S. Marine Corps, but he's a veteran of two presidential administrations and time on Capitol Hill as a chief of staff. And he draws a great background in federal regulatory policy, payment policy, legislation, and law. And he's been at the center of all of the work that we've done on Capitol Hill and with the executive branch over the past 4 or 5 years, works very closely with Richard Knight. And this is the type of quality leadership that we have at AAKP. And if you're watching, we encourage you to jump on board. We're influential in a lot of different areas, but we can always use more help and more patients involved in the discussions that happen in Washington, D.C. and state capitals that impact your life and the lives of your families. As Ed mentioned, AAKP does a significant amount of polling, and through our Center for Patient Education and Research, we have several different slides that we'll walk through here that show the latest insights of people's understanding of Omicron and what they're doing proactively to take care of themselves and their families during this period of time. Much of this data is what was used by our doctors today to formulate their presentations and also to prepare them to answer your questions that you've asked over the past several weeks to us, and we've been able to assemble many of those that we'll go through today. So let's go ahead and start with the first slide if we can. On this slide, we're asking people if the initial information they've gotten on how to take safety measures and to protect themselves during COVID have been helpful, and also with the Delta and Omicron variant. And as you can see, most folks feel like in the initial wave of information, they got pretty much what they needed in terms of tools to use. And if you take a look at the second item here, about 86% of the folks feel like they had a good initial guidance on masks. But where this has actually gotten pretty interesting is when we ask the question of, have you found recent public and media discussions about the best types of mask confusing or unclear, 63% of our respondents said yes, it has gotten confusing and unclear. And that's understandable when you see multiple levels of conflicting guidance in news stories on what is safe and what's not safe. And again, it's why our experts from George Washington University are here with us today, and they'll walk you through many of these types of issues. In the next round, we had asked our patients, for those who had been infected by COVID or a family member or a friend, when were they diagnosed and what was their vaccination status? And this is pretty interesting for us as an immunosuppressed or immunocompromised population. You can see the percentages of those who did get an infection or had an infection in their family, what level of vaccination had occurred. The bottom number is the most interesting. Nearly 40% were among unvaccinated. But for those patients who are either with a kidney transplant or dialysis or chronic kidney disease who are compromised, you can see how the stories and the research that have been done about the efficacy of the vaccines, we have a tougher time as a population getting things to work for us. And it's why we have to take so many different measures to protect ourselves. They're an important tool, but they're not a guarantee of safety. On this slide, we asked for the different types of mitigation strategies that people are currently using. And you can see that our population is fairly well educated. We're using the tools. We know what we need to do. The most interesting point on this one is the data on online shopping. That number has fallen from nearly 80% about a year ago down to 50%. And so hopefully if folks are going out and doing things, they're doing it safely. And that number is an interesting one out of all the different measures that people are engaged in. And then this is just two questions here to gauge people's sense in terms of relative risk, more or less concerned. And as we go into 2022, you can see it's about an equal split from people who are more concerned or less concerned about their safety with COVID-19 at the start of 2022. Unsure is 17%, and that's really some of the folks that we're trying to reach today so that we can get them the most accurate information that's unbiased. And then in this slide, specifically on Omicron, we're asking whether or not folks feel more or less safe than they did in the prior 2 years. And you can see with more safe, it's about 35%, less safe, 40%. Again, that unsure number is important. And the issue here really is, do you know what it is? Do you know what the risk is? And what are you doing to protect yourself? The 40% number of people who feel less safe 2 years into battling this is an important one. And those folks we'll be talking to today as well. And then this is an interesting one because you're starting to see a pivot in the media among experts about Americans just need to get over it type of thing with COVID. And so we asked folks about how they felt about this and whether or not they get concerned when they hear messages like that and how it might impact them as an immunocompromised person or an immunosuppressed person. Again, transplants, dialysis. About 57% of our respondents say they are concerned when they hear statements like that. And unsure is about 25%. And there's reason to understand this because if folks are stepping away from COVID, obviously the concern is that people will be acting less safe in society and in our communities. And that means that we will have to be even more vigilant for ourselves. This is one that we ask every year. It's the frequency with which people get flu shots. Kidney patients know they need to be proactive. We're pleased to see that nearly 75% of the folks have gotten their flu shot. I'm certain that the doctors will be talking today to the 5% that are planning on it, and also to address some of the issues related to those at 21% who are saying they haven't been receiving or did not get their flu shot this year. Again, we thank you for watching this today. We think you'll find it very interesting in light of all of the media stories and everything else. To have two great experts here from George Washington University Hospital is just fabulous for us and fabulous for you as a patient community. Now I'd like to go ahead and turn it back over to our all-star, Erin. Go ahead, Erin.
Thank you so much, Paul, for sharing that great data. And thank you to Ed for opening us up today on this webinar. We thank each of you for listening to us today, and especially those who shared your responses to this flash survey. At this time, I'd like to introduce today's speakers and thank George Washington University for selecting these speakers and putting together such a great presentation. Dr. Ehsan Nobakht is an associate professor of medicine at the George Washington University School of Medicine and Health Sciences. He graduated from Tehran University of Medical Sciences and completed internal medicine residency and nephrology fellowship at the George Washington University. Dr. Nobakht is board certified by the American Board of Internal Medicine in both internal medicine and nephrology. He has published many abstracts, book chapters, and papers published in reputable peer-reviewed journals such as Nature Reviews Nephrology, Kidney International Reports, and American Journal of Kidney Diseases. Dr. Nobakht is the medical director of the Falls Church Somatis Dialysis Unit that offers in-center hemodialysis and also various home-based renal replacement therapies. He has served as medical director for COVID-19 designated dialysis facilities. We're so pleased to have you today, Dr. Nobakht. Our speaker today is Dr. Divya Shankar, Assistant Professor of Medicine in the Division of Kidney Diseases and Hypertension at the George Washington University. She is board certified in internal medicine and completed her nephrology and transplantation medicine training from Weill Cornell. Her clinical interests include precision medicine for genetic cause of kidney disease, immunosuppression for transplantation, management of rejection in transplant patients, and COVID-related kidney disease. Dr. Shankar has several publications in high-impact journals in topics ranging from urinary cell transcriptomics in acute rejection to dialysis in COVID-19 patients. Dr. Shankar has presented on several AAKP webinars, so you may have seen her in the past, including on topics like advancements for highly sensitized patients and on the monoclonal antibody treatment webinar. We are thrilled to have her presenting once again. I'll go ahead and turn things over to Dr. Nobakht to start us out. Thank you.
Hello, everyone. Thanks for the nice introduction. Thanks to AAKP for inviting me today. First of all, I have to mention that COVID-19 pandemic is a very evolving situation. And even for the purpose of this talk, I had to change and update my slides a couple of times over the past week. This is how science works. The science is evolving, the new data comes, and we adjust ourselves accordingly. So let's start with some statistics. More than 300 million cases of COVID-19 have been reported, with more than 5 million deaths globally. In the United States, there have been more than 60 million cases, with more than 800,000 COVID-19 deaths. And this is the official report, and the actual number can be even higher. And those individuals with pre-existing conditions such as obesity, diabetes, heart disease, lung disease, liver disease, and our patient population with kidney disease are at increased risk of COVID-19 complications. 12% of our patients with kidney failure and dialysis have got COVID-19 infection. And unfortunately, our dialysis patients have disproportionately suffered from complications of COVID-19. And the death rate, the mortality rate in this patient population have been 26%, which is a very huge number compared to general population, this is 4 times higher. Looking at the data, the death rate during the pandemic in the patient with end-stage kidney disease and dialysis, and comparing that with the data, the death rate before pandemic in 2019, we can see up to 10,000 excess death. And this excess death is likely due to the weakened immune system in our patient with kidney failure. Also, they usually have comorbidities such as diabetes, hypertension, heart disease, which can contribute in this excess mortality. Also, majority of the patients with kidney failure, they receive dialysis in the dialysis unit. So they have to frequently travel to dialysis unit, and this increases their exposure to the virus and limits their ability to isolate and do the physical distancing. So I shared with you the significant burden of COVID-19 on our patient population. Is there any encouraging news? Since early in the pandemic, the nephrology community, dialysis providers, kidney patients all try to fight back against the virus. We started doing the screening for everyone who comes to the dialysis facility. We did the separate waiting area, and we provided dialysis to those who had the infection in the dialysis designated facility or COVID-19 designated shifts. And also with regards to the masking, we were proactive. Even before the CDC recommendation, we started asking everyone to wear a mask in the dialysis facility. Also, we ensured that our cleaning procedures can kill the coronavirus. And the early data showed that when we used this measure, when we adopted this measure, the rate of infection declined. And the other encouraging news is that now we have therapeutics. The development of the vaccines was a major milestone in this fight. And the vaccines are not perfect, but they are highly effective against severe disease and death. Now we have monoclonal antibodies against the virus. We do have immunomodulators, which are even useful in the treatment of the infection. Also, we do have antivirals such as remdesivir and other newly authorized medications such as Paxlovid. But can we use these therapeutics in our patient population, in the kidney patient, which I will get into it? The immune system of the patient with kidney failure and dialysis is not as robust as the patients without kidney disease, or those individuals without kidney disease. So we were initially concerned that their response may not be acceptable to the vaccine. But the data is showing majority of the patients on dialysis, they had a good response to the vaccine. So the vaccines are serologically effective in dialysis patients. They produce excellent immunity in dialysis patients, but we need to be mindful that the level of antibody can fall over time. And I'd like to highlight the importance of the booster shot, which is needed 6 months after the last dose of the 2 mRNA vaccines from Moderna and Pfizer. And if you have got the Johnson & Johnson vaccine, after 2 months, you are eligible for the booster shot, and we advise you to get your second immunization with one of the mRNA vaccine, either Moderna or Pfizer. So despite all of these efforts, the COVID-19 pandemic remains a public health crisis. The new variants are emerging, and the most recent one is the Omicron variant, which is considered a new chapter in this pandemic. So we have learned from the experience with the other variants, alpha, beta, delta variants, that these variants are associated with the new waves of infection, which can be all around the world. With regard to the Omicron variant, it was first reported from South Africa, and quickly it became widespread. And now Omicron accounts for the majority of the new cases of COVID-19 infection in the United States. So what are those characteristics of the Omicron? So Omicron is highly transmissible. Compared to all other variants we know so far, Omicron is more contagious. And the other important health implication of Omicron is impact on the vaccine effectiveness. The data from South Africa and UK showed that the vaccine effectiveness declined to 35%. But the good news is, when the booster was administered, that can restore the vaccine effectiveness up to 75%. And now the data here we have in the US is showing the similar trend. The booster shot was increased the vaccine effectiveness to 90% against the COVID-19 hospitalizations, compared to 57% among those who did not get the booster shot. With regard to the prevention of the visits to emergency room, the vaccine effectiveness was increased to 82% after the booster shot, compared to only 38% in those who did not get the booster. How about the unvaccinated? So not surprising, the highest rate of infection with the Omicron was among unvaccinated, more than 700 cases per 100,000 people. Those who received the primary series but no booster had lower rate of infection, 250 per 100,000 people. And the patient who received the booster had the lowest rate of infection, 150 per 100,000 people. So that's why CDC highly recommends everyone to receive the booster shot, including our kidney patients. And the reason I keep repeating over and over the importance of the vaccine is because the vaccination is the best tool we have in this fight. One of the questions that we get frequently is, can Omicron variant of COVID-19 cause serious disease? The answer is yes. Serious or life-threatening infection can occur with Omicron, but it is less frequent in those vaccinated and boosted patients. And the people who do have the protective antibodies, the patient, those individuals can get the infection, but it appears to be mild or asymptomatic. So how about the impact of the Omicron variant on the therapeutics? Recently, FDA authorized the use of Paxlovid to treat COVID-19. After the Omicron variant emerged, there was some concern that Paxlovid may not be effective against Omicron, but early data in the lab setting shows that Paxlovid is effective against Omicron. But the question is, can we use it in our patient population, in kidney patients? So Paxlovid can be used in patients with mild to moderate kidney disease, but those patients with more advanced stages of kidney disease, Paxlovid is not recommended. And in patients on dialysis, the use of Paxlovid is not defined. And the same story for other therapeutics such as remdesivir. There was no formal evaluation in our patient population, in kidney patient. And this has been a challenge because the kidney patients have been systematically excluded from clinical trials, and this is a very important challenge that we have to address. How about the impact of the Omicron on the neutralizing antibody? So the early data is showing that unfortunately Omicron is showing resistant to some of the monoclonal antibody. One of them appears to be effective, and also Omicron is showing resistance to the protective antibody from prior infection. That means reinfection can happen. You may see in the news, in social media, that Omicron is no big deal, it's just a common cold, let's intentionally get the infection, get it over with. So I have to say, this is a horrible idea to intentionally get COVID-19 infection. Every variant of COVID-19, including Omicron, is dangerous and can cause severe disease and death. And you may get long COVID. And when I say long COVID, I'm referring to those residual symptoms of COVID that may last for a long period of time. Fatigue, persistent cough, sometimes memory gap, like foggy brain. These things can happen. And the other important thing is the hospitals can become overwhelmed. Just assume a dialysis patient comes to the hospital for a COVID condition or a non-COVID condition, and the dialysis can be delayed for that patient, and that can be life-threatening. So it is a horrible idea to saturate, to overwhelm the healthcare system. And also I showed you the data that the monoclonal antibodies are not working on Omicron. Only one of them appears to be effective and is already in short supply. And more infection will result in further virus mutation. And I'd like to say that if you have chosen to be unvaccinated, somehow you have chosen to be an ally to the virus, because you are giving the opportunity to the virus to keep replicating, to keep mutating, so it can learn how to escape our weapons, our tools. It can learn how to escape the protective antibodies, either from the vaccines or from the prior infection. So get vaccinated and boosted and avoid infection. How about those patients with chronic kidney disease, not on dialysis, those patients with mild stage of chronic kidney disease? So it appears that COVID-19 and chronic kidney disease has a bidirectional relationship. Having mild chronic kidney disease can increase the risk of COVID-19 infection, and COVID-19 infection can lead to acute kidney injury, which is the sudden onset drop in the kidney function. And this can happen even in those individuals without pre-existing kidney disease. And this can lead to persistent kidney function requiring short-term or even long-term dialysis. If acute kidney injury happens in the patient with pre-existing kidney disease, that can result in further decline in the kidney function. So we have been saying that kidney disease can increase the risk of complications of COVID-19, but how big is this risk? What is the impact of kidney disease on the COVID-19 related death? If you look at the bar on the left side, you can see the COVID-19 related mortality is more than 3 times higher in dialysis patients. And even in those patients with not on dialysis with advanced stage of kidney disease, stage 4 and 5, the risk of COVID-19 related death is higher than diabetes or even heart disease. Even the patient with mild degree of chronic kidney disease, stage 3, there is still increased risk of COVID-19 related death. So what should our kidney patient do to protect themselves? So in addition to vaccination and receiving the booster, mask is very important. The way that the COVID-19 transmission has been a controversial issue. But I think it's safe to say that a simple cloth covering may not provide the optimal protection. So it's reasonable to upgrade your mask. And also you need to pay attention to the ventilation of the room when you are in the indoor setting. So what type of mask you need to use? You need to make sure you have a well-fitted mask or a respirator such as N95 mask to have the optimal protection. And there is a formal way to make sure the mask is fit, but I can share with you what I have been doing over the past 2 years. When I use my N95 mask, when I breathe out, I make sure I don't get fog on my eyeglasses. And if I see that, I try to adjust my mask. So despite the concerted efforts by dialysis providers, nephrology communities, kidney patients, COVID-19 continues to spread and is causing serious illnesses, and it has exacerbated the shortages we have in the staff and the dialysis supply, which is a very critical issue. And also with regards to the therapeutics, it has been always challenging to use the new therapeutics in our kidney population because the kidney patients have been systematically excluded from clinical trials, and this is an important challenge that we need to address. So in summary, COVID-19 continues to spread around the world and new variants are emerging. It is a horrible idea to intentionally get COVID-19 infection. Every variant of COVID-19, including Omicron, is dangerous and can cause severe disease and death. People who die from COVID-19 are much more likely to be unvaccinated. So get vaccinated and boosted, and also get your flu shot. And also it is very important to have a well-fitted mask or a respirator to have the optimal protection. And news headlines, social media feed can be deceiving. Always contact your doctor before making a decision which may impact your life. And thank you.
Thank you, Dr. Nobakht. We will now turn it over to Dr. Shanka to share her presentation.
Thank you so much, Erin. I'll try to cover the topics related to transplant and immunocompromised patient and the Omicron variant. Carrying forward what Dr. Nobakht has already mentioned, this COVID seems to be a challenge. We've been dealing with it for the past 2 years, and it keeps coming up with new variants. And like he said, science is always evolving, and we have to keep up with new information as scientists find about this disease to update our practices and guidelines. So to start out with, Dr. Nobakht already presented the data on how severe COVID can be. And this is data from a paper that was published in 2020 in the American Journal of Transplantation. Is COVID-19 infection more severe in kidney transplant recipients compared to the general population? And you can see that on this study, what they found that compared to the non-transplant population, the transplant patients did have an increased risk of acute kidney injury. They did end up needing more dialysis than the non-transplant patients, and the death rate was in the transplant patients because of COVID was 17.8%, whereas in the non-transplant population, it was 11.4%. But there is some good news. Along the same lines, what we also found eventually was that vaccination does reduce the rate of mortality in the solid organ transplant patients. In this data from UK, what they looked at was the incidence of COVID infection and death in patients due to COVID, depending on the number of vaccine doses and whether they were vaccinated or not. And similar to what Dr. Nobakht has already mentioned, when you compared the unvaccinated patients to those who received either one or two doses of the vaccine, you can see that the incidence of the SARS-CoV infection, while in the unvaccinated patients it was up to 3,500 cases, as the number of vaccines were given, it significantly comes down. And so are the death rates, which is much more in patients who were unvaccinated as opposed to those who got two doses. Now, this data is as of July 2021, when we were still getting two doses of vaccine. SARS-CoV infection has been devastating for transplant patients, but the vaccination has been efficacious in reducing the death rate in these patients. Now, before we delve further, I would like to explain some very basic concepts to our audiences. I think in the past 2 years, a lot of complex medical terms have been used in news and media that I think a common man who does not have much of a medical background would find really difficult to follow and interpret. Our body has an immune system that protects us from infection. Now, the way our body knows whether an infection has entered our body or not is because it is capable of differentiating what is self from non-self. So, any cell that is not self will trigger your immune system. And the main cells that are responsible for this acquired immunity are called lymphocytes. In this image, the virus, which is depicted in blue, let's say it enters the body, the lymphocytes get activated. And the way these lymphocytes are able to detect that there's a virus in the body is by detecting specific proteins on the virus, which we call as antigens, that in this image I have depicted as a yellow antigen. So once the lymphocyte has detected a virus based on these antigens, the lymphocytes gets trained, gets specialized, and can either form antibodies that go and attack the virus, or the specialized lymphocytes themselves can go and attack the virus. So these are the two main responses that we get, which is the antibody-mediated response and the cell-mediated response. These specialized lymphocytes are very specific for the target for which they have been devised. So let's say instead of these yellow antigens, let's say there were green antigens present, then these antibodies and these cells will not go and attack what they don't recognize. So in this way, our immune response is highly specialized and highly specific. These two responses are able to tackle anything that is foreign to our body. And this is how when the body is attacked by the virus, whether it's the virus or whether it's the vaccine, our body is able to differentiate between the two. Now, each time our body encounters this antigen, its response gets escalated the number of times it gets exposed. So let's say during the first exposure, there's a X amount of antibody response. If there's an exposure to the antigen again, now the antibody and the cell response is much more accentuated than the previous time. Now, this is the reason why we recommend the vaccines, the boosters, because each time the vaccine is given and there's a booster that's given, it increases the response of the body to tackle the virus if anyone gets infected. Now, those of you among the audience who are taking medications like tacrolimus or rituximab, those that are called immunosuppressive medications, you know that these medications reduce the effect of lymphocytes. So these cells that respond to these infections or these vaccines, those are already being blunted by the medications that you're taking in order to avoid a rejection. And that is the reason why immunocompromised patients require the boosters in order to make their body more equipped to fight in case they are attacked by the infection. Whether it is the vaccine, whether it is the infection, or whether it is a kidney transplant rejection that happens, the number of times you encounter the antigen, each time your response is much more. So with new science that keeps developing, the first data that are usually derived is from animal source, and then we extrapolate that into humans. So now that we know that there are two arms for the immune system, the antibody response and the cell mediated response, which of these is more important in order to fight this COVID infection? Because we've been hearing a lot of information about testing your antibodies, whether antibodies are important or not. So, based on animal data, we have understood that both the antibody response and the cellular response is important and protective in SARS-CoV infection. So what they found in this study was when they transferred the antibodies from convalescent monkeys to naive monkeys, it was able to impart some protective function in those monkeys. And what they've also found was when they depleted these lymphocytes in the convalescent monkeys, it reduced the protective efficacy of these natural antibodies. Hence, they concluded that the cellular immune response can contribute to the protection even if the antibody responses are suboptimal. Hence, the importance of the SARS-CoV vaccine to induce potent and durable humoral as well as cellular immune responses are important. Having gone through the first dose and the second dose, the question was whether a third dose is going to make a difference and whether a third dose is going to be protective. In this study that was published in the New England Journal of Medicine, they looked at 120 solid organ transplant recipients. Hence, these were all immunocompromised patients. And this was a double-blind randomized control trial, which is considered to be the highest level of evidence when you're interpreting any research. And they looked at the levels of the antibodies, and they also looked at the cellular responses in these patients after they received the third vaccine dose. And what they found was a third dose of this mRNA vaccine in transplant patients had substantially higher immunogenicity. If you look at the graph that is provided and you look at panel C, you'll see that compared to the placebo, after a third dose, there was significant increase in the neutralization when the patients were given the vaccine, as opposed the placebo, which is depicted in blue, there was hardly any response. And in panel D, which represents the cell-mediated response, compared to those who got the vaccine, you'll see that the response in placebo, depicted again in blue, was significantly lesser. So now that we keep getting challenged by newer variants, and every day, like Dr. Nobakht mentioned, the data keeps evolving and we have to keep updating every day. When the Omicron emerged, the question again was, is vaccination effective against Omicron, or are we again back to square one? This data, which has been published but not yet peer-reviewed, they looked at 51 kidney transplant recipients to study the effect of the third dose. And what they found was there was significant increase in neutralization against the Delta variant and Omicron. However, the neutralization was much lower for the Omicron compared to the wild type or the Delta. So if you look at the panel, depicted in gray is the response before the third dose, and the red panels represent the effect after they received the third dose. So compared to the wild variant, which is mentioned as WT, the Delta variant had a significant response to the third dose. The Omicron did have some response, but it was significantly lesser than what the Delta variant responded. So in conclusion, the third dose does have some effect against Omicron, but much lesser than what it was for the previous variants. And also, 89 days after the third vaccine dose, 3 of their patients developed symptomatic COVID, but none of them required any hospitalization. They were managed by giving outpatient monoclonal antibody. And what's more important is that none of these patients developed any donor-specific antibody or did not develop any rejection. Now, the other concern that most of us have been having is, having received a vaccination, we do hear a lot of people still getting infected. But the bigger question is, what do these breakthrough infections in immunocompromised patients, what do they look like? And this was answered in this paper that was published in the Transplantation Journal, where they looked at around 3,000 solid organ transplant recipients. And out of those, 26 of their patients had breakthrough infections, of which 23 had received 2 doses and 3 of them had received only 1 dose. So their breakthrough rate was less than 1%. All of them were symptomatic, and about 50% of them were managed as an outpatient with early administration of the monoclonal antibody. But even among those who were hospitalized, so 50% of them needed hospitalization, of which 2 were admitted within 28 days of receiving the monoclonal antibody. 12 of them received the antiviral medication and treated with steroids. Only 5 of the 3,000 patients had severe COVID, of which only 2 of them died. So you will hear of breakthrough infections after vaccination, but what is more important is that you don't require the rates of hospitalization, the rates of intubation, and the rates of death have been much lesser in those who have been vaccinated compared to those who have not been vaccinated. With so much data that have been coming out and this changing science, based on the available evidence that is currently there out in the scientific field, the American Society of Transplantation and the Heart-Lung Society of Transplantation released this joint statement regarding vaccination on the 30th of December, which I think is kind of sums up everything that we know and everything that both providers and the individual patients and their loved ones should be aware of. So the transplant recipients have diminished responses to the COVID-19 vaccine compared with the general population. The protective components of the cellular and humoral responses cannot be linked in the individual solid organ transplant recipients. What it means is whether you have lesser antibody response doesn't mean that your cell-mediated response is going to be low, or if you have low cellular response, you won't have any antibody response. These two components are not directly linked in one particular individual. It is possible to have an active immune response even in the absence of antibody and vice versa. Additional doses of vaccines are safe and well tolerated without any increased risk of rejection. Antibody testing is not required prior to additional vaccine doses, and it is not being recommended by the FDA currently. We highly recommend that all eligible adult transplant candidates, that is, even patients who are on the wait list, and all the transplant recipients be vaccinated. And those who are on the wait list, particularly relevant to them, whenever possible, vaccination should occur prior to transplantation, ideally with completion of vaccine series a minimum of 2 weeks prior to transplant. Pertaining to living donors, it's recommended that the living donors be vaccinated with a minimum of 2 doses of vaccine and the booster to be given. And this is more so that it reduces the risk of perioperative infection, because once you're in the hospital setting, you're going through the surgery, they are exposed to other people in the hospital, increases their risk. So to minimize that, living donors are also recommended to be vaccinated adequately. And also all eligible household and close contacts of solid organ transplant recipients should be vaccinated. Again, this is to break the chain that we've been trying since the beginning of the pandemic. If there are people around an immunocompromised patient who contract the virus, even if they don't develop severe infection, their chances that they will pass it on to our immunocompromised patients are always there. Hence, the close contacts and all household members should also be advised to be vaccinated. This point is probably the most important that we need to deliver to our patients. And most of the transplant recipients who received their transplant prior to the pandemic, I'm sure they would also know from what they have been educated at the time of transplant. COVID is new, but the being vigilant and being careful is not new for an immunocompromised patients. We always have recommended that during the flu season, all our transplant recipients take adequate precaution. We have always recommended that even prior to COVID, all our patients get all their vaccination, including the flu. So taking due diligence and making sure that you're safe has is and always has been advocated for our immunocompromised patients. So, keeping that in mind, while the COVID-19 variants continue to evolve and circulate in the community, and the extent of protection is still unknown in transplant recipients, it is recommended that solid organ transplant candidates and recipients continue to adhere to protective measures, including masking in public spaces, social distancing, frequent hand washing, and avoiding indoor crowds. And these measures should be followed regardless of the patient has received additional doses of vaccine or not. Recently, the CDC issued an advisory statement regarding the fourth dose for moderately and severely immunocompromised patients. So, transplant recipients who fall in that category have been, there is a guideline advising to get a fourth dose of the COVID vaccine. The other change that was made was for this fourth dose, the interval has been shortened from 6 months to 5 months for the Pfizer vaccine. The booster interval recommendations for those who have received the JJ vaccine and the Moderna has not changed. I just briefly wanted to touch upon some guidelines that are being adopted, that have been adopted for organ donors, because a lot of recipients who are on the wait list have concerns about accepting organs from donors who may have had COVID. So, since the pandemic started and when organ transplantation was resumed, all deceased donors are tested by an RT-PCR test of the respiratory tract within 72 hours, or ideally as close as possible to organ recovery. So, all deceased donor organs are tested for COVID. And patients who are lung donors, those donors are further tested by getting lower respiratory tract testing. In addition to that, those who have had previous COVID infections, they have to, the organ procurement agency makes sure that they have a negative PCR test. And we already went over the data for the living donor. So overall, whether the organ is being procured from the deceased donors or from living donors, everyone is screened to make sure that they do not currently harbor the virus. And if they have had an infection, that they have recovered from all the symptoms to make sure that they are now completely symptom free. Now, switching gears, I quickly want to also cover the topic about the monoclonal antibodies. As we already learned about the antibodies in the previous slides, monoclonal antibodies are genetically engineered by humans. So, as opposed to your lymphocytes producing the antibodies, these are generated in the lab so that they can go and attack specific antigens. So, let's say you create one monoclonal antibody against a red color antigen. Let's say now the virus changes the antigen and it's now in green color. The same monoclonal antibody will now become ineffective against this new antigen. And this will help most of our audience understand why the monoclonal antibodies that were previously developed are not effective against COVID anymore, or at least the new variant, the Omicron. So, like Dr. Nobakht already mentioned, among the different monoclonal antibodies that have been developed, for the post-exposure monoclonal antibody for mild to moderate COVID, only sotrovimab has been found to be effective, and this has to be given ideally within 5 days of symptom onsets or testing positive for COVID. So all our transplant patients at GW, what we have been doing is we have been advising all the patients first to stay safe, and if they start developing symptoms, we advise them to get tested, and once they are tested positive, we advise them to come either to our ER or any of the ER that's closest by to get the sotrovimab as soon as possible within 5 days. And based on my own experience and the experience of my colleagues at GW, we do believe that it has made a significant difference. Based on this study, there was an 85% relative risk reduction for disease progression leading to hospitalization or death. And we do know that the sotrovimab neutralized the Omicron variant much better than the other monoclonal antibody, although it is less effective. This is a treatment that is available for patients after they have been exposed to the virus and if they are tested positive. Now, like all these treatments that we've had since the beginning of COVID, this is available in very short supply. Not all centers may be carrying this monoclonal antibody. So there is a discrepancy between the demand and the available supply. So in order to address that, there has been the CDC and the NIH and the AST have come forward with providing a list on how we can prioritize these patients who are at the highest risk for progression for severe COVID. And most relevant to our audience here, patients who are within 1 year of receiving any B cell depleting therapy such as rituximab or alemtuzumab, any lung transplant recipients, no matter how old or how long ago their lung transplant was, or patients who are within 1 year of receiving a solid organ transplants, and any solid organ transplant recipient who recently received a treatment for acute rejection within the past 1 year. So among our patients, if you fall within any of these categories, then you are considered to be at a high risk, and priority will be given to you to receive these monoclonal antibody if you have been tested positive for COVID or if you start developing symptoms. Now, this is for post-exposure monoclonal antibodies. We now have monoclonal antibody, which can be given even before you encounter the virus. That is, as a pre-exposure. So these are people who are otherwise safe, who are at home, haven't encountered the virus, but they think that they are at a higher risk for infection if they encounter the virus. So the AST issued a statement for the use of this monoclonal antibody for pre-exposure prophylaxis. A lot of you may have already heard about this, which is named Shield, which is now available for pre-exposure prophylaxis. Based on a trial, it showed that there was a 77% reduction of infection compared to placebo at 183 days. Now, more data is awaited about the duration of protection beyond 6 months. The monoclonal antibody has been modified so that its effect lasts beyond 6 months, but we do not know exactly how long it would work, especially in immunocompromised patients who are taking medications that reduce their immunity. We do not know the effectiveness specifically in the transplant population, and also its activity against the Omicron variant is still not known. What needs to be stressed, however, is that the monoclonal antibody is not a substitute for vaccination or masking. Continue follow social distancing and avoid large indoor social gathering. Just as the post-exposure monoclonal antibodies, because U-Shield is also available in very short supply, there have been, again, patients who can be stratified as to those who will benefit most from getting a pre-exposure monoclonal antibody. So these would be patients who have completed the full series of vaccine but have not developed adequate response, which is based on the antibody testing that is now available. People who are more than 60 years of age or have 2 or more comorbidities, lung transplant recipients, and patients who are on immunosuppression, such as our transplant recipients who have received any recent B cell depleting therapy, T cell depletion, or the induction agents that are used for transplantation. Now, to briefly touch upon the oral antiviral therapies that's available, as Dr. Nobakht already mentioned, 2 recent drugs were developed. One is Paxlovid and the molnupiravir. Paxlovid is especially challenging to be used in transplant patients because a lot of you who are on medications such as tacrolimus or cyclosporin, this drug interacts significantly with those medications and will alter the levels of the drug, and it becomes a challenge to constantly monitor the levels and make sure that you don't have high therapeutic levels, and that will require frequent clinic visits and lab visits. So the Paxlovid is not recommended in transplant recipients based on this statement issued by AST. The other drug, molnupiravir, has been found to have relatively low efficacy, and it has not been evaluated in transplant patients. So based on this, the early use of either an appropriate monoclonal antibody or outpatient intravenous remdesivir for 3 days may be preferable in transplant outpatient candidates as first-line therapy to prevent progression of this COVID disease. The bottom line, a few takeaway messages that I would like for our audience to know is our understanding about COVID-19 is constantly evolving. We are still learning. Both the providers and the patients and their loved ones are constantly learning as more data evolves and as science understands. And also as this virus keeps mutating and coming out with new variants, our understanding of the disease is also evolving. We know that the SARS-CoV-2 virus has infected a lot of people, but it is the good news is also that a lot of people have recovered as well. The immunocompromised patients are at a higher risk for complications compared to the general population from COVID. You can still get COVID after vaccination, but the good news is that it prevents you from getting sick or from dying due to COVID. And I think that is more important because it prevents you from getting hospitalized. You don't lose your days. You don't spend your time in the hospital. The newer antiviral therapy have significant drug interaction with anti-rejection medications in the transplant populations. The monoclonal antibodies are recommended for patients who are at high risk for severe COVID and those who do not mount an adequate response to vaccination but are available in very limited supply. So what I would recommend, or what we have been recommending to all our patients, is if you think you have contracted the illness or if you've come in contact with someone who was positive, let either your primary care doctor or your transplant provider know so that we can monitor your symptoms, so we can direct you to a facility that has the monoclonal antibody available so that you can get treated as early as possible. But that does not take away from the fact that continue to monitor and maintain vigilance, continue to mask, maintain social distancing, make sure that you have completed your vaccination series, and be as vigilant as you would have been even prior to the pandemic, because being immunocompromised is not new to our patients. It's the virus that is new to us. Thank you.
Thank you so much, Dr. Shankar. Wow, this was a very informative presentation by both Dr. Nobakht and Dr. Shankar. We have several questions that individuals have sent in to us, and I know many of those questions have been addressed during these presentations, but it would be great to reiterate some of this information. So I will ask some of these questions and ask that either or both of you respond to them. So one of those questions is, what do I do if I get Omicron, and how do I know? How does it differ from the Delta virus? And when can I go back to work? How long should I quarantine?
So I can take that question. Thanks for the great question. If you have exposure with someone with COVID-19, or you are tested positive, regardless of the variant, is it Delta or Omicron, you need to isolate yourself for 5 days. And after you become symptom-free, then you can come out of the isolation, but you need to wear a well-fitted mask for additional 5 days.
Thank you so much. Dr. Shankar, did you have anything to add to that question?
No, the only thing that we've been doing additionally for our transplant population has been because they are immunocompromised, they will probably harbor the virus much longer than the general population. So we do ask them to quarantine for the 5 days, watch for the symptoms. Usually once their symptoms are resolved, I think it's safe for them to go back to work. But like Dr. Nobakht mentioned, we do advise them to continue wearing a mask so that they don't spread the infection more.
Thank you. And I think if there is one thing that individuals can take away from this webinar, it's that it's important to still wear those masks.
Correct.
And we do have several questions about masks. One of them is talking about the fake N and the KN95 masks that are common out there. How can individuals find the legitimate N95 and KN95 masks that they should be using?
So thanks for the great question. So there are poorly made or fake N95 masks available in the market. And there is a list in CDC that for the approved manufacturer that it can be used. And also always you can contact your doctor as well, but there is a list available in the CDC website for the approved manufacturers.
And we will see if we can get that link posted on our website on our coronavirus resource page so that people can quickly access that. With the Omicron virus variant, do individuals still need to wipe down their mail, packages, groceries that they get like they did at the start of the COVID pandemic?
So thanks for the great question. So there is no evidence that food packaging and handling the mail can transmit the virus, but you need to assume your hand is contaminated after touching the groceries, mail, and you need to continue with hand hygiene.
Thank you. We have some questions that came in from transplant recipients. With transplant recipients being immunocompromised and not building many antibodies, are recipients really benefiting from the vaccine? And I know, Dr. Shanka, you talked about how important it is to remain vaccinated, but can you speak on that a little bit more?
Sure. So, as I've already shown in the data, you can see that the vaccination does help. It has reduced the rates of hospitalization. From my own experience that we've seen in our transplant patients here at GW, we do find that our vaccinated recipients have been doing significantly better, even with the Omicron. So I still recommend, measuring the antibodies in a lab is not yet approved, and because the immune system is so complicated, doing one test in a lab is not necessarily going to reflect what is actually happening in your body, because as I showed, after you receive one antigen, let's say you now get exposed to the infection, you may produce an antibody once you're exposed. So having the antibody or not having the antibody based on the tests that are done in labs currently available is not a scientific way, and it has not been standardized. We don't know exactly what is the level of protective antibodies that we need for COVID. So vaccination does work, both from the data and from my own experience. We've seen a lot of vaccinated patients have been doing well. Of course, you might still contract COVID. You might still harbor the virus. You may still have some cold-like symptoms. You may still develop fever. But vaccinated individuals, transplant patients, have not required prolonged hospitalizations. They have not required prolonged intubation. So I don't think you have to give up hopes on the vaccine yet. It definitely works. Maybe less than the general population. So that's why, to add more to your shield, continue to wear masks and continue practicing general hygienic measures.
Thank you. And I believe you shared on one of your slides that the FDA has not approved the measuring of antibodies. So that is an important piece, I think, to touch on, since so many individuals are asking about when to check for antibodies, and the concerns that they have that they haven't built up those antibodies as they have been expecting that they would. So I appreciate you touching on that.
Yeah, because the test is so new that we don't know the levels at which the antibodies are protective. All the research papers have used a certain number based on available data from previous studies. So getting tested is one thing, but how to interpret the test is very difficult. So that's why the FDA doesn't approve of getting these tests done. But having said that, there are people who still get tested, and those who have no antibody available. That's why the CDC has come forward with recommending a fourth dose. So like we've seen, as data evolves, we'll know more about it. And as the variant becomes less virulent, maybe our protection also will get better.
Great, thank you. And could the use of antivirals in transplant patients help keep any of these variants at bay?
So the antiviral will only be recommended if once they've received the infection. So the protocol that we have been following here is if one of our patient gets tested positive, if it's within the 5 days, we recommend that we've been pushing for them to get the monoclonal antibody. And the advantage of monoclonal antibody is it prevents them from being hospitalized. So they come get the monoclonal antibody and they go home. If they are beyond 5 days, that is beyond the window for monoclonal antibody, then they are treated with remdesivir and dexamethasone. And like I showed, those two antiviral medications, the newer ones, are not recommended. What we have been using is remdesivir. And so far, from my experience, patients who were out of the window for the monoclonal antibody, those who were treated with remdesivir and dexamethasone, even after this Omicron variant has come, they have had good outcomes. None of them required to be on oxygen and where they're discharged without any consequence. So I think compared to 2020 when the pandemic started, we are better equipped. We do have more tools in our hand. And I do think that monoclonal antibodies, the antivirals, the vaccines, masks, all these together have equipped us better than what we were in 2020.
Thank you so much. So I'd like to bring both of you back on and invite you to share any parting words with us. But thank you so much for these presentations. You have touched on so many different concerns and questions that our kidney patient population has. So I appreciate that. But look forward to hearing any parting words from you. Dr. Nobakht, we'll start with you.
Sure. So COVID-19 virus has shown to be unpredictable. So we need to stay vigilant, we need to sit tight, and that means get vaccinated and boosted, wear a well-fitted mask, and also continue with the hand hygiene, physical distancing if possible, and make sure when you are in the indoor setting, you have a good ventilation.
Thank you. Dr. Shanka, any parting words?
Yeah, to continue with what Dr. Nobakht said, it is evolving. I think what is also challenging is that now with the news and social media, I would recommend all our audiences to educate themselves better so that you can interpret the data that is being given to you. Make sure that if you're drawing some conclusions to take decisions about your health, make sure you're drawing them based on adequately well-researched data and not from blogs or social media that can be misleading. And continue to follow these measures at least until, if not for you, at least for everyone around you, because if you help to break the chain, you're making it better for your family members and your loved ones as well.
Thank you so much. We greatly appreciate your time, and we will close the webinar now with just a few closing slides from AAKP. If you're not already a member of the American Association of Kidney Patients, we encourage you to join us. We offer free membership to patients and family members, as well as living kidney donors. To become a free member, you can join online or give us a call over the phone. And to receive all of the benefits of membership, please be sure to include your email address when signing up. As a member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our print magazine, AAKP Renal Life. AAKP is dedicated to helping patients understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and caregivers. By visiting our website at aakp.org and clicking on the AAKP store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download. We are pleased to share that our 2022 events will take place virtually to ensure that all can participate. Our Global Innovation Summit with George Washington University School of Medicine and Health Sciences will take place in May. Our Policy Summit is scheduled for June 30th, and our national patient meeting will be September 21st through the 23rd. And we encourage you to visit our on-demand webpage where you can find educational sessions from these previous events. We continue to keep our coronavirus resource page updated. You can access this page from our aakp.org homepage, and the recording of this webinar will be made available on the page in the coming days. We'd again like to thank today's speakers from George Washington University, Dr. Nobakht and Dr. Shanka, for sharing important updates about COVID and the Omicron variant. We hope you all will continue to be informed and stay safe. Thank you.